Lori, talk to us some more. We've been talking about the steps. When someone is discharged from the hospital, you'd made the statement, which I loved hearing. The minute somebody comes through our doors that needs the hospital, there's already a plan being created for them upon discharge.
Exactly.
So that they really have this continuity of care.
Right.
And oftentimes the doctor will write orders for home health as part of the need. So,
exactly. So the first step is, of course, the admission process, the admission visit. The admission visit to home health typically will take quite a bit longer than the average visit. Once we get started, we'll be in the home around an hour for each visit. But with the admission visit, we're typically there an hour and a half to 2 hours. I mean, it takes longer because you're looking at the home. You're doing a complete assessment of the medications because a lot of times, especially with chronic disease, people are coming out of the hospital with new medicines. They don't know anything about them. You need to go through all of them, make certain that they're on the ones that their physician wants. Okay? So that visit takes a little longer than the average visit. So they'll be there a while assessing the environment, getting orders for physical therapy if they need it, getting orders for occupational therapy if they need it. That'll take a little longer. But then after that visit, during that visit, that patient should get a pretty good picture of what we're going to do for the next 8 weeks.
Right.
That's considered an episode of care. That's what Medicare says. When there's an order for home health, we get 8 weeks.
Okay. That's called an episode of care.
That's called an episode of care. Okay. And patients actually, you know, and we will be doing a lot of teaching. We'll be helping them get set up in their home so that they're healthy. Hopefully they stay healthy during that 8 weeks and they progress and everything goes along and they get stronger and stronger, and then at the end of the 8 weeks we discharge them. But sometimes, because we're dealing with humans and human bodies, things happen. You know, they have a little step back. They take a little step back. But we do our best to keep them in the home during that little step back. Maybe get them to the doctor's office for a different medication, maybe call the doctor, get a little different something to help meet their need depending on what's going on, and keeping them in the home. So we really become the eyes and the ears for the doctor in the home. And really our focus, because everything is going to outpatient like we talked about, is to communicate with that doctor in the clinic and working with getting that patient whenever they need in the home to stay in the home.
And that's exactly, nobody wants to be in a hospital. I mean, it's...
Right, you know, exactly. So in answer to your question, the patient in that admission will know what steps are coming. Next, they may see a physical therapist if they need. They may see a physical therapist the same day they see the admission nurse if we have, and it is a little overwhelming sometimes. Sure. But if we have somebody coming out of the hospital that we really want to work hard on, they kind of have to understand that very first day home, you know, the second day, first day home, we'll be in the home the second day as much as we can be. And so there may be a therapist and a nurse that day if the doctor's ordered therapy. So it might be kind of
all the therapy's done in the home, and and the physical therapist brings all of the tools that they need to strengthen and help the patient.
It's all there in the home. And of course we can have a social worker come in if the patient has needs as far as they need. Maybe they need to make arrangement for some help. Maybe a personal care aide, somebody to run errands for them, somebody to do their grocery shopping. The social worker can help them figure out maybe that can be paid for.
What resources, what
maybe
resources are available.
Yeah, maybe, and we run, our social worker runs into that a lot. She runs into patients that have no idea that they qualify for a program that would help them pay for personal care.
That's why it's always so important to get that resource information out there. I know that Muruck Family Education Center on Aging has a great resource guide called the Helpline. And those are free, so anybody just call the Muruck Center.
Yeah, the Muruck Center is a great resource for all of our patients with chronic disease. They have the wellness groups and support groups there to help people with all sorts of chronic.
As they get further down the road, they can continue on with exercise programs and support groups, like you said, to get the latest and greatest information that's out there. That's,
they know because they're keeping up with those diseases. So.
That's a great. So go back to on the telehealth. I'm trying to envision this, and I'm trying to, So is this something? You said you need a landline, so they've got a phone that it's attached to.
Right, it's attached. There's a hub. And it's attached to electricity. It has, and then also the phone line.
Right.
And then as long we call them devices, there's a little blood pressure cuff, and it's like a automatic blood pressure cuff.
Oh, okay. That was what I was trying to envision.
Kind of like what they would have an automatic blood pressure cuff, like you might buy at Walmart or Walgreens or where wherever you get to your where your pharmacy is. But it's a little box, okay, with a blood pressure cuff attached, and then there's another little box with a pulse oximeter to measure oxygen levels, and it's just a little wire. It's a little clip.
Okay.
A lot of our patients are familiar with that. They've had it done in the hospital.
So they put that on their finger, and they put their finger, and that wrist through.
And then they put their wrist through and put the cuff on to measure the blood pressure. And then our scale is a really good scale. It goes up to 400 pounds, so our larger folks can weigh. It's very low to the ground. It can go on carpet. Okay. It's very wide, so it's easy to get on. It's safe. It's been designed and developed for people who are older and have health problems. So the scale is easy to use. And all of those have to be within 20 feet of that hub.
I gotcha.
They communicate wirelessly to the hub. Then the hub is what does a lot of the work. The patient doesn't have to do anything, though. All they have to do is push the button and take the measurements.
Right.
Check their blood pressure, check the oxygen level, step on the scale. The scale even talks to them. It tells them what to do. It'll say step off, and then it talks. So a blind patient could actually weigh themselves with this. They would hear the weight.
Okay.
So
that is technology, and then all of that information goes over the phone line, back to your headquarters.
Right.
Okay.
Back to a computer.
Back to the computer, and all of that information is then reviewed.
Right.
And suggestion from there is, I think we better call the doctor. There's
exactly. We can call the doctor. We can fax him a report. Some of our physicians that use telehealth like us to fax weekly, just so they can stay updated, just so they can know what's going on with their patients.
And this is important for patients to know that you may have only been with the physician 15, 20 minutes.
Right.
But there's a lot going on behind the scenes.
Exactly. He's getting information from a lot of providers.
Sure.
Yeah. So,
to make sure that your health really, it's being monitored.
It is. It is being monitored, definitely. So,
Now, one of these days, and I'll just say it right here, I know that eventually you're going to be moved out to the Cotter area.
Yes, we
You're
are.
going to be merging.
We are. Our county offices, Baxter and Marion.
Baxter and Marion are going to merge.
Will come together because we've been separate. Marion County office has been in Yellville, and we've been here in Mountain Home. We're going to come together at Cotter, which is kind of right there on the line, and it's a perfect place. So, we're going to be out there at the clinic. I heard today that we did get a date for the cubicles to go in November. So that's the latest.
Keep your fingers crossed.
Keep our fingers crossed that we'll be going into that office sometime in November. We certainly are hopeful.
And that really, by centralizing everything, sounds like a great idea.
Centralizing will work. It'll be much easier.
So that you've got nurses. And now that I think that'll help too with getting sometimes the same nurse back out to see the same patient.
Right, and that is a big thing with chronic disease, and we're really, that's one of the things I'm really trying to work hard on and emphasize, and we actually have a chronic disease nurse for each one of our areas here in Mountain Home. We have Baxter County divided up into 4 geographical areas, and we have a chronic disease nurse for each one of those areas.
That's wonderful.
To have that continuity, so she keeps that patient on her load and no one else sees her. We are a big agency. We have 200, 240, 250 patients sometimes. And so we do have to use our PRN staff some, but we like for them to see those patients that are not chronic disease, that are other, we have them for other reasons, of course.
And that's, and this is something I always try and stress when I've got nurses, registered nurses on the show, is that for whatever reason, when I've talked with folks, they kind of say they went through nursing school. Then they've gone through all this other training to specialize. And that's ongoing. That is not anything that ever stops. That's every single year. You've got more and more training that you're doing.
Exactly. And that's part of being a professional nurse, is to be responsible for that continuing education in your area of specialty. And so when you're being cared for by our nurses, you're being cared for by a nurse who specializes in home health.
Which is wonderful.
It's a totally different area than the hospital. but it's very rewarding.
Yeah, bedside care is so different from home health care.
Exactly.
And people don't always realize that that's the case. When they think about it, they do.
Yeah. Oh, yeah. If you really think about delivering care in the home, you've got to understand that it's going to be different.
Very different.
And taking care of a surgical wound in the home is much different, or starting an IV. Any of the skills a nurse does, in the hospital at the bedside is some of them, a lot of them are done in the home too.
Yeah.
But our emphasis is teaching.
Yes.
We like to teach the patients and their families, and that's really what we're there, a big part of why we're there. Anyway.
Do you, I wanted to ask too, on the occupational therapy, everyone would have a pretty good idea what physical therapy is.
Right.
Would you go over occupational therapy?
Yeah, thank you. Yeah. That is the problem starts with its name, occupational therapist. Everybody wants to think, well, occupation means job. They're going to help me with no. It has absolutely nothing to do with it. And I'm not really certain how they got that name.
Yeah.
But no, they actually, their emphasis, what I was told years ago by a therapist is that basically physical therapy and occupational therapy divide the body. Okay, the physical therapist work on the legs,
extremities,
and the occupational therapist works on the upper, the arms. And that's kind of how they got. Then their focus is the arms, shoulders. We have a occupational therapist that specializes in hands.
Oh, that'd be
at
Crystal.
The hospital. Crystal Henry.
Yes.
Right. And so occupational therapists help people use their hands and their upper body so that they can do what they need to do in their life, in their activities of daily living. That therapist is there to help them do, and they ask, "What is your goal? What do you want to do?" We've had occupational therapists that have worked with patients to, maybe they only have one extremity they can use. And they work with them in order to learn how to do whatever it is they need to do for themselves. Teaching someone with diabetes how to monitor their blood sugar with one hand.
Right.
Okay, that's an example.
Yeah.
How do I put a blood pressure cuff on with one hand? Those challenges. How do I put lotion on my back with one hand? I mean, those are challenges that an occupational therapist can help that patient meet.
And the tools that are available, I've got
endless.
Yes.
Yeah. You're right.
How to reach things.
How to reach things. How to
do your back with that lotion.
Put the lotion on the back. Endless things. Occupational therapists are amazing. The other thing they do that I just learned this the other day myself is low vision. They can actually work with someone who doesn't have good vision, and there are occupational therapists that specialize in that. I did not know that.
I did not know that.
But that's kind of so. Because if you think about it, it makes sense. Because we use our eyes to to do our care and our activity. We use our eyes, and they can work with low vision. So somebody out there has issues with vision.
And I know too, when you go through, when you were talking about the assessment nurse comes in, one of the things they're looking for is not just is the path from your favorite chair or your bedroom to the restroom clear. Is it bright enough?
Yes. Is it bright
enough? Good lighting is something that seems to not always be
always there, and that does contribute to falls. And we do have a night light that we can get to our patients now.
Oh, wonderful.
We can actually give them a night light. If they do not have a night light or can't afford to get one, or maybe they don't have anyone to go get them one.
It's a real good night
it's
light.
It's a good night light, and we give them that way if lighting is an issue with a fall. They need a night light in their bathroom. Maybe they need a night light in their hallway. But yes, not only do we look to see if they can safely move to the bathroom, but we look, part of safety is the lighting, is the ability, you have to be able to see. You need to use all your senses.
Yep.
Yeah.
Lori, this has just been delightful today. I am so
enjoyed it a
glad.
lot.
Would you come back and visit us again
sure
real
will.
soon? I want to hear all about what's going on with home health. I want to see if you really get moved.
Yes, we really get moved. Yes, chronic disease.
We've been teasing about that.
Yes, we have been. We have been. But we are seeing good results with our chronic disease program. We're excited.
It's a great program.
It is.
So beneficial, so needed in this area. So come back and see us again real soon.
I'd be glad to. Thank you, Donna.
Thank you, and thank you for joining us today for BRMC's Healthy Connections, and we will see you again next week.